All right, guys, I think we're going to get going because I have 416 slides, so it's really important that we start on time. For those who don't know me, I'm Noam. I'm one of the PGY4s. Once again, I am still in the program, despite the fact that you may not have seen me in the last 7-8 months. And this is a talk on a conference I recently went to in San Diego called Reanimate. So if anybody is on the Twitterverse, this is intentionally hashtagged here because you can actually see all the tweets that occurred. And we'll talk a little bit more about what happened at this conference. I want to start with the case. This is a case that I had. I was the Resus 16 at the jail. We had a patch call come in from EMS where there was a VF arrest with multiple ROSCs that happened at Linda Lane. So you could see it from the window of the hospital. This is a gentleman that came in with EMS who had ongoing mechanical CPR when he showed up. We took off his mechanical device. We ran through ACLS for almost 50 minutes. We shocked him at least 13 times. I think it may have been more than that. With ROSC a number of times, never sustained. We gave him MAG, we overdrive paced him, we gave him calcium, we gave him everything else that we could, and ultimately this gentleman died. He was 45, controlled diabetic with no other comorbidities. And that was one of the hardest family meetings that I've had, in which I had to tell this wife of his that he died and I couldn't fix him. So I felt like leaving that, it was quite unsatisfying in terms of the fact that ACLS failed this person. So the objectives today are to talk a little bit about what was going on with the folks in San Diego, as well as a number of international physicians who are doing quite outstanding things in their ICUs and emergency departments, and then discussing how at Sharp Memorial, which is in San Diego, they've drastically improved their cardiac arrest management because of some of the programs they've started. And then talk about how ECMO may be coming to emergency departments in Canada. So these are the real objectives, outside of what's stated, is that I want you to that ECMO is a reality. I want you to think about how we can better run our arrests in TOH, specifically in the emergency department. And I want to convince you that I think we should have an ED ECMO program at TOH. There's a number of people I want to thank. They're too numerous to list, but all of these people I've had direct contact with in preparing for this Grand Rounds. Initially, I just wanted to give a little chat about what this experience was like, and it turned into a bit of a longer term assessment than I had anticipated. I'd like to thank Andrew, who unfortunately couldn't be here today, for helping me out with my slides and guidance throughout this whole thing. And of course, thanking the real people who keep me sane despite nerdy haircuts. I wish I had something to divulge, but despite the fact that I'm actually talking about specific products in this, I'm getting nothing from anyone. So this is the location of where I was recently. So this is at UCSD, University of California in San Diego, at the medical teaching building in the beautiful sim lab that they have set up there. And there are these three guys at Sharp Memorial, who some people may recognize from the ED ECMO program. Zach Shiner on the right, Joe Belezzo next to him, and on the far left is, or your far right, would be Chris Ho. If anybody's recently heard that smack talk of ECLS a step too far, or ECPR, that's Joe Belezzo and Chris Ho, and then of course that's Scott Weingart, everybody I'm sure is aware of. So these are the guys that started the ED ECMO project, and at Sharp Memorial, they are running this program where they are cannulating seed to nuts as the emerge docs. Chris Nixon on your right, my left, other way around, is of Life in the Fast Lane fame, and to his left is Jason McClure, who is the medical director of the Alfred ICU, which is in Melbourne, where they've been running ECMO for a number of years. And they actually do some retrieval medicine, which we'll talk about in a little bit. So they also came to help out with their expertise in terms of what they're doing with ECMO where they are. Of course, I was in the land of organic energy drinks, and I thought that is the most bizarre thing I've ever seen, so I had to put that in. So how it all started for them in San Diego is that they determined that, similarly to what I'm describing in that case, is that they were having these arrests where they were running out of options, and they couldn't fix things that, in theory, were fixable problems. So they decided that they were going to run ECMO. They were going to cannulate in ECMO. They are a level 2 hospital with no residents, and there are 3 of their doctors that will do the cannulations, and they will do it in their department. So their very first case, July 28, 2010, was a 59-year-old male patched into their medical director who essentially was complaining of jaw pain, who was diaphoretic. He had a bit of a soft pressure, but otherwise well. And then they got another patch coming in saying that he had just coded and was in VF in the ambulance with them. So he came in. He got 68 minutes of CPR with a mechanical device. They put him on ECMO, at which point they said this is a non-survivable arrest, until he started checking his watch in the ICU. They took him to the cath lab. They reversed his 100% LED occlusion, and he walked out of the hospital 9 days later, neuro intact. This is Ralph. So Ralph Berry, from many years ago now, so 6 years, quality of life, has been healthy, well, living a quality life since this happened in the emergency department, where they theoretically saved a non-savable person. So I think it's very important that we go over what ECMO really is, because it's got this mythical lore to it where everybody thinks it's a very scary thing, and it is, but I think that if it's a healthy respect, it's something that is a lot more accessible than we realize. So ECMO, like intubation, doesn't fix anything. It just buys you time to fix another problem. So this is a bridge to a cure or to a fix or to a transplant. It is not something that is going to save a life strictly by putting somebody on ECMO. This is everything, essentially, that is required for an ECMO circuit. This is what it's become now. So if you see here, this is the Maquette Cardio Help, iCardio Help, which is essentially the motor. It is your brain, your computer. This is the tubing that's required. This is a manual drive. That's just for emergencies. This is your oxygenator and your pump. Okay? Well, this is just that, but broken down. And this is your cannulators, what you're putting into somebody's generally femoral vessels when you're doing this in an emergency department setting. So as you can see, it's really not that magic mess of wires that you've seen. And Brendan Ritchie did a similar talk to this 2 years ago, and I recall a picture he put up, and it was like this frightening Nightmare on Elm Street kind of picture where there's wires and things. And that's what it was, and it has been coming down since then. This is the unit itself. So this is a centrifugal pump that is also the oxygenator, which you can see here. And as you can see, these are all sort of micropores where your blood's running through. It's connected to an oxygen source. You oxygenate your blood. And then through here is where you're drawing out your CO2, which is a bit of a wider space. So you both can oxygenate and remove CO2 with these circuits. Both of those are disposable elements. This is just the face screen that you can see. There are really not a lot of elements to control in terms of the physiology when somebody's on an ECMO pump. This is your revolutions. So similar to what Shabazz has shown us on LVADs, right? It runs somewhat similarly in terms of you're generating some type of centrifugal force, you're getting a flow rate, and then that's debatable about what your flows are needed, but generally somewhere at least 3 to 5 liters per minute. You have a negative pressure generally with your venous side because you're sucking blood out, so pre-pump. You have an arterial pressure, which is post-pump, so you're generating forward flow, and then obviously your delta P. And then generally to try to make sure you have enough oxygen in your system, you're looking at your central venous O2. Really, that's it. And this isn't a responsibility of people that are necessarily putting people on pump, but this is what perfusionists do, is maintain these parameters so everything is running appropriately. This is the machine itself, again, from Maquette. So you can see that this whole unit, when it's all plugged in, is about 10 kilos, so 20-ish pounds. So it's not big. This here is a magnet, which is what generates your centrifugal flow. So that's what your oxygenator is plugged into in order to get forward flow. Everybody loves physiology, I know. So we're going to make this, physiology for people like me, which is simple. This is the circuit. You put a femoral line in, it's pre-pump, generates negative pressure, it goes through your oxygenator, which generates flow by the machine. You get a forward flow coming out, and this goes into your aorta. And so you're actually getting retrograde flow up your aorta. and that's what is perfusing both your cerebral and coronary vessels. So you can imagine, let's say you had some kind of major issue with your aortic valve, like aortic insufficiency. This then becomes a major problem putting somebody on ECMO because you're just going to flood your whole heart. So that is, in some centers, contraindication, so it's just always something to keep in mind. In terms of what you're doing pre-bypass, everybody who's on a circuit is heparinized because clotting is an issue. A lot of the new tubing is bioline coated, meaning it's heparin impregnated. So it means you need less heparin, but you still need some. You need an O2 source to hook it up to. And the problem with having an open central line, as you can imagine, with negative pressure is you're sucking air, and air in a circuit is bad news bears. With the perfusion, the flow rates that you're looking for, as I said, is you're looking for somewhat physiologic flow rates, so somewhere in the range of 3 to 5 liters per minute, depending on who you are, and that's based on your revolutions. And as long as you're keeping your central venous O2 above 70%, that means you're oxygenating adequately. Your ABGs are going to help you understand and adjust where you need to go with both your CO2, as well as your oxygen flow rates and the amount of oxygen that you need to put in. So they do have mixers in terms of your air that you're putting in, whether or not it's 100% O2 versus some element of room air. Generally, when we're putting people on VA ECMO or veno-arterial ECMO, which is the only thing I'm talking about and the only thing I'm proposing today, you just leave it at 100% O2. Sweep gas is essentially how many liters of oxygen you're connected to, and all that does is actually increase the amount of CO2 you're getting out. So that is not actually to adjust your oxygenation, it's to adjust your ventilation, essentially. Systemic vascular resistance also applies in this because you still need to perfuse your tissues. So some people will need vasopressors, some people will need vasodilators. It's all an element of what is happening clinically with the person at that time. So what does ECMO look like? This is ECMO. This is 100% of everything that you need outside of the tubing and the patient. This is not very big. You can see, obviously, at the top there, you have your ECMO machine. At the bottom here, you have a heater, so something that you're able to maintain temperature, because as you can imagine, if you don't do that, people will get cool very, very quickly, and sometimes you don't want that. This is just an amplifier down here. This is a flow mixer, so if you are in any way trying to change your flow settings, so you can imagine with a VV ECMO or ARDS, that's what you're doing. This is your emergency hand crank, so if your motor fails, you literally just turn it and you can generate flow. And then this is your oxygen source here. So as you can see, this is directly from the maquette handbook here. It's actually indicated in their own brochure that this is for transport. So obviously, people can't stay in the emergency department if we put them on this. But the reality is this is in an ambulance. They have all of these portable little equipment bags that you can use here. They have an element that can actually attach it to gurneys. And they actually do transport people by air on ECMO. And as we were talking about with some of the guys in Melbourne, they are retrievalists. So they will get phone calls saying, I have a person who's failing, not for VA, but for VV. They will fly out to them 2-3 hours. They will put them on VV ECMO, and then they will transport them back to their ICU. So this is something that is safe in order to move. So if we think about where we would need to move them from our department, you think it's relatively minimal. So what does ECMO really look like? This is ECMO. Right? So you have a patient, you have something at the head of the bed that looks very similar to a ventilator, really doesn't take up much space, which is always an issue, especially in our emergency departments. Is this feasible to have in terms of being able to maneuver around the patient and treat the patient appropriately? And you can see that it just sits at the foot of the bed, and then you can move it the same way you would move an IV pump. Now, who gets put on ECMO? This is really the million-dollar question, because we have a whole lot of arrests that come through our department. And we don't want to just be putting people on this willy-nilly, because then we're going to end up with a lot of the problems and very little of the benefit. So this is a great quote, I think. This is showing that for the most part, and this is not 100% of the time, but I would call it well over 90, these are people that are 100% dead, and we are trying to give them some other mechanism to make them survive or help them survive to get to a point where they can actually have quality of life. At Sharp Memorial, this is one of the very few published documents or research that we actually have on this. So this is what they did in their department between 2010 and 2011. So their inclusion criteria was minimal, but their exclusion is what's more important here. So they essentially say if you're dead or in shock that we can't fix with fluids and our normal elements that we would use, then we will consider putting you on ECMO. However, if you are not getting CPR immediately after your arrest, if you are arrested for more than 60 minutes, if you have a whole lot of problems that are comorbid and making you poor protoplasm, we don't want to put somebody like that on ECMO because their chance of being weaned is extremely, extremely low. And of course, anything else like sepsis or hemorrhage, which we feel like ECMO wouldn't necessarily help. There's no point in putting them on something that is futile. At the Alfred right now in their ICU, so this is based on one of their cards that they have, which I will show you after. These are the guys that published the CHEER trial we'll talk about after, and this is very similar to their criteria that they used for that trial specifically. Again, anyone over 65, they will not put on ECMO. If it's unwitnessed, if it's asystolic, and again, poor protoplasm, or for them, it's 45 minutes of CPR rather than 60 minutes. So you can see it's relatively stringent, but you can also see why this would be a problem for us in the emergency department is because we're always, or often, working off of incomplete information. So a lot of this is a judgment call, and this is something that the guys at Sharp will tell you frequently is the most difficult decision. Like doing a thoracotomy, the hardest part of the procedure is deciding to do the procedure. So this is interesting now. So as some of you will recognize, St. Paul's is actually in Vancouver, where they are now running an ED ECMO program. So this has been going since January, and as you can see, very, very similar criteria. So the people who have strict criteria are all tending to go towards the same type of criteria at this stage. Nobody over 65, no asystolic arrests, unless it's witnessed with immediate CPR. Again, no poor protoplasm. It has to be assumed to be cardiac or PE. That's something you can fix, as we said. And then hypothermia has a little bit more of that extended time frame, and there's been some very, very good outcomes with cases that I've been secondhand involved with relatively recently with long-standing arrests in hypothermic patients. So the cannulation itself, how does it actually work, and how would we do this? The first step, depending on the site, if we are doing this, and when I say cannulation, we're talking percutaneous rather than cut-down cannulation, which is what they're doing in emergency departments that I'm speaking about. The first step is to cannulate your femoral artery and your femoral vein. In San Diego, they're doing that. It's the emerge docs who are doing it. In fact, everywhere it's the emerge docs who are doing that. They will either put an A-line or some 7 French introducer sheath into the artery, and they will put a larger French, some 10 to 12 French into the femoral vein, so you then have access. If you are in Sharp Memorial, again, then it would be the emergency docs who upsize the cannulae, and then they put in the longer ECMO cannulas. Once you have access to your vessels, so this is what they use. They have an Amplatz super stiff wire that's 260 centimeters. So you can imagine how long that actually is and how that is not something that you can do with one person. So you need somebody there who's actually helping you with the wire. There's Amplatz super stiff, extra stiff, stiff. This is the one that they have decided is better. And it makes a big difference because the problem is if you kink your wire, you're in a lot of trouble when you're putting in an ECMO cannula. So you can imagine that there is some fine handling of this that needs to happen. This is what it looks like once the cannula are in. So generally speaking, the arterial is up to the hub. The venous cannula is supposed to sit right around the atrial junction. So that's something where they're using ultrasound to actually make sure that it's in the appropriate spot, especially if your cardiovascular surgeons are the ones cannulating. The emerge docs are free to actually use the ultrasound to help guide that in. This is their fancy sim model. They have all kinds of sim models at this place. It's crazy. So this is Walt Dembitsky. And one of the reasons that their program at Sharp works is because he is a cardiovascular surgeon that supported them from the second they decided to get started. He gave us a talk while we were at this conference entitled, "Does it take a surgeon to cannulate for ECMO?" His first slide said no, and he probably could have stopped the talk there. He's a great guy. In this slide, he's actually showing us how to do cut down. So if there is a problem with your percutaneous cannulation, you are able to just expose your vessels and then that way have a better idea, because it is difficult to do percutaneous, especially in an arrested patient. As their prolonged arrest, their artery gets smaller, their vein gets bigger, and oftentimes you don't have flows to separate out which one you're actually cannulating at the time, which you can imagine becomes a problem when you're cannulating 2 veins or 2 arteries and trying to put somebody on ECMO. The other interesting thing about this slide that I want to show is that the Canadians actually outnumber the Americans in this slide. So this is Kish Leister here. who is an ED internist out of Saskatchewan. This is Joseph Finkler, who's also at St. Paul's, where they've already got an ED ECMO program. And this is some weird guy who I'm sure you also recognize, depending on his facial hair configuration. This is Zach Shiner, and like I said, Walton Bitsky. So now, again, the other million-dollar question, does ECMO work for out-of-hospital cardiac arrest? So you can imagine, as with any kind of resuscitative procedure, critical care, in something where it's difficult to say, how are we going to do a randomized controlled trial with this? There's not a ton of data, and there's extremely little prospective data. So a lot of this is case series, a lot of this is retrospective in places where they're doing a lot of it. But this is what we have available to us in order to see that there is some survival benefit. So this is what was published by Joe Belezo and the Sharp Memorial team. This was in 2012 based on their first year experience of ECMO. So the question is for them, did it work? And they had 5 of their first 8 patients that they did leave neuro intact. 2 of those were cardiac lesions. 1 was a PE, 1 was hypothermic, and 1 was a type A dissection, all of who did extremely well. And their ranges of time on ECMO were somewhere between an hour to an hour and a half to somewhere like 40 to 50 hours, depending on what the cause of their arrest was. This is their current data that Zach was kind enough to send to me, where they're at right now. So you can see the number in red here. Their survival to discharge rather than neuro intact. So I don't know if they're neuro intact, but they're getting about 6 of their 25 that they've done. So again, not a common procedure, but they're all getting, and we'll see this after, the majority of people are getting somewhere in the range of 20 to 30% survivability, neuro intact, with out-of-hospital cardiac arrest. There's also some data on in-hospital cardiac arrest, and it doesn't really apply to us at this point. I think we need to focus on one before we focus on the other, and certainly in the emergency department, that's where our bread and butter is going to be. This is the only prospective data that I can find on ECMO itself, and unfortunately, it doesn't utilize ECMO in isolation, which makes it difficult to interpret, but it does show us that it has some efficacy. So this was done at the Alfred, where they used a bundle package involving mechanical CPR, hypothermia intra-arrest, so they're infusing cold saline, as well as ECPR, or ECMO initiated in their department by their intensivists, or ICU consultants as they're called there, and then ideally getting them to early reperfusion. So how did they do? Right? So you can see, again, not a very large sample size, but this is not something intended to be for a large number of people. They had 1/3 of their out-of-hospitals, and almost 2/3 of their in-hospitals leave neuro intact. So these are people, again, who would be 100% dead, who then were able to walk out of their hospital and at 1 year still be completely independent living. Currently, this is what they're showing me. This is not 100% up to date, but what Chris Nixon was able to share with me at this point is that of their 47 out-of-hospital arrests since that year trial, they've put 21 on ECMO, again with 5 of 21 leaving neuro intact. Again, right around that 25% mark that is very common based on all the literature, retrospective or otherwise. And in hospital, again, they're getting close to 50% of people. And as you can imagine, the infrastructure for in-hospital is going to be significantly better. This is something that was just published. Again, retrospective. They've done some propensity analysis. A lot of the research is being done in Asia, and I don't necessarily want to call it research. A lot of the ECMO is being done in Asia. So Taiwan, Korea, Japan, China, they're doing a lot of retrospective, and their criteria for putting people on ECMO is really much looser than what you're seeing with the criteria we've talked about today. So they're not getting as good results. However, in this analysis where they're looking at this one place in Taiwan, the use of ECMO is associated with an odds ratio of 25 for leaving neuro intact, which again, you know, when you think about the numbers, that's not that surprising. If you're going to get 100% death versus any survivability, you should expect some type of odds ratio that's improved. And as you can see down here, this is 40, what they call standard CPR versus eCPR, 10 survivors of their 28 neuro intact. So it's still quite good numbers, relatively speaking, if you consider the alternative. The ELSO is a repository that was developed in Michigan, where they have been doing ECMO for quite some time. This is a listing of every case. It's similar to ROC, if you consider it as some type of analogous system, where if you are listed as one of their ECMO centers and you're registered, you can input all of your ECMO cases. So as we can see here, their eCPR, which they don't discuss or separate in hospital versus out of hospital, but you can see out of 2,400 cases almost, they're still getting 30% survivability, and that's to discharge. So again, not neurointact, so we would expect that to be perhaps a little bit lower. However, it is an efficacious modality. So this is again showing us that there is some benefit to doing this. This is also on their site, also showing us that there's been almost an exponential growth, both in the number of ECMO centers as well as the number of ECMO cases that are being run internationally every year. So this is something that people are buying into. It is something that people are figuring out how to run appropriately, and I believe that it is a viable program in a number of tertiary care or quaternary care centers. So how does SHARP do it? So this is an interesting thing because SHARP has gotten much better at their cardiac arrest because of ECMO. It's got nothing to do with getting better at ECMO because of their cardiac arrest. So I think this is the mantra for most elements of resuscitation. It's why we do SIM. It's why we do oral exams. It's why we read and reread and then do over and over again. So we become somewhat robotic with an element of understanding of our situations so we can free up our cognitive space. So what Joe Bellezza was saying is that the way they run their ECMO and the way they cannulate their ECMO is crucial to have everything where it's supposed to be when it's supposed to be there, and that's not something they're able to do unless everybody buys in and everybody is able to be part of that team. This is their specific structure that you're looking at, and they run it every time that an arrest comes into their system. So when you can see here, their alpha doc is their airway doc, who will initially intubate if they're not already intubated. Their beta doc down here is the one who is also one of the cannulators. They know exactly where their ultrasound is going to be. They know exactly where their nursing staff is going to be. They know exactly where all of their Mayo stands are going to be and their ECMO cannulae. And they also have other people outside who are able to help them get things as they need it because, as we all know, inevitably you need stuff all the time. It brings up one of these concepts, which is gaining a lot of traction right now in sort of resuscitation literature, which is called pit crew CPR, or team-based CPR, depending on how you want to call it. There's a lot of published data that I could find that actually was in any way kind of controlled. So this is one of the centers in Wisconsin where apparently they are very good at resuscitation, which is, I guess it's not just cheese. So they have shown that, you know, based on this study where they're doing team-based training, and this is you know, along the lines of what I think people are doing here excellently with in situ simulation, as well as more of the multimodal sims in our sim center. This just showed that they got better at their defibrillation times. You know, not quite significant here, but it is showing that people get better, which is again not shocking. It would be difficult to try to figure out how we would run that at TOH because we have 4 million residents and 16,000 staff, and you know who's working with who. But if that was built into programs, perhaps we could find a way where we would be able to run that. These are the, I don't want to call them name tags, but position tags that they have at the Alfred. So similar to what we do with our traumas where we put name tags up, everybody's getting a lanyard with one of these where it's showing them what their role is, what their responsibilities are within their role, and if you look here, exactly where everybody's standing. So it's again, this is sort of a 2-in-1 showing you if I am responsible as the cannulator 1, I am on a step-by-step basis doing X, Y, Z, and that way it is not really confusing to anybody in the room because everybody knows what their role is. This I thought was very interesting, which they've started doing at SHARP, in that when they are deciding to cannulate, they will pass their ship on to one of their nurses who will then run the CLS element of their code. So why is this a good thing? I think that all three of these reasons are significant in terms of our ability, and as we know in terms of stress inoculation training as well as cognitive overload, it's very difficult to do more than one thing at a time. So let's say you're putting in a chest tube and running a code while somebody's trying to intubate, all of a sudden things become extremely chaotic and you lose control of the room. Whereas this allows you to focus, if you're cannulating, strictly on your cannulation because you know that that's going to be a high area of potential error. Again, not a lot of literature on this, but this is something that I found where they're showing that when they compared senior nurses to junior doctors, they're showing that in terms of their ability to recognize VFib, to shock VFib, to run a room, to communicate within that room, they do as well as, if not better, based on this system than the physicians who are doing it. And oftentimes we are seeing juniors running codes, but we do have that supervision of senior staff in the background. So I don't know what this necessarily means, and I don't know if that's something that we would be able to implement at TOH. However, it's something that's interesting that they're doing. Mechanical CPR is this extremely controversial element, I think. I am a very big proponent of it. I'm definitely a big proponent of it in these situations. I believe that in EMS transport, it would be beneficial. And I mean, this is a debate that we don't need to get into necessarily today. However, when you look at the data that exists, we know that mechanical, based on high quality manual compressions, so a compression fraction almost equal to what you're getting with your mechanical device, they do just as well as each other. But if you consider what's happening, let's say in a hypothermic arrest, where one recently in Kingston where they did 2 hours of CPR, there's no way that you're going to maintain a compression fraction equal to the firefighters or the police or the EMS involved in these studies for 2 hours straight, especially when you consider the variability that exists within the people doing CPR, even within our own department. So med students, any of the other assistants who are there, you know that one person to the next, you're not getting the same quality CPR necessarily. So they put a Lucas in San Diego, an Autopulse in Melbourne, and I believe Autopulse in St. Paul's on every single arrest that's coming in if they're considering cannulation. And at Sharp, every single person gets a Lucas, and then that frees up all hands around the patient. It makes it more easily accessible to get in and out of various areas because you don't have people rotating in and out for CPR, and you know the quality of compressions that you're getting. This, I think, is the most telling slide in the fact that in Sharp, in 4 years, because they decided to start doing ECMO and look at how they were running their arrests, they've over doubled their survival rates in terms of their out-of-hospital cardiac arrest, and it's because of these 4 things that they have really changed. When they talk about ECMO itself, ECMO does not change this survival even 1%. So ECMO is very good for the patients that it's needed for, but oftentimes we don't need ECMO, so we need to be figuring out how can we be better at running things when we don't need fancy modalities or more complex systems. So then we get to the fact that, it's all fine and good. They're doing it in the States and in Europe and Australia and the UK and Canada, really? So I'm sure a lot of people remember this fine young man who was part of our program. So this was his case that we all heard about because all the Vancouver guys were at San Diego, and I had the chance to talk to them, and they were getting text messages saying that Omer had just put somebody on ECMO. So they had a gentleman who was found by police in one of their rivers or lakes or creeks or various tributaries in Vancouver, and he was in there combative for a while until he became unresponsive. EMS showed up, port temp 24. They took him to St. Paul's, where he was put on in their department, and he was discharged neuro-intact 5 days later to psychiatry. So this is the time frame of what they were able to do, which I think is extremely impressive. So they have a pre-hospital notification if they believe somebody fits into ECMO criteria. So you can see right away that they have involvement of their pre-hospital teams. From arrival to the department at 8:24 to ECMO, it's 24 minutes. This is not a process that needs to take a long time. From the time of arrest or with EMS to flow is 45 minutes, right? The interesting thing here that we can consider is, so 24 minutes in a code, I think that probably all of us here would say that we, on average, spend more than that within the code itself. And additionally, this is a person who was transferred to the CSICU for ongoing care with ROSC, or return of spontaneous beating, as they may need in ECMO. So when we talk about flows, because that's always a consideration for us in the emergency department, is this going to impede our flow? Is this going to sink our department every time we do this? And the reality is this may actually be faster, potentially, than us just running a standard ACLS code, especially somebody in refractory VFib, where we're going to run that code for quite a long time. Or you can consider that an hour to an hour and a half. There's lots of stories out there of people getting shocked 50 times because you keep getting ROSC. So this is actually a good thing, in my mind, in terms of flow. Obviously, there's family meetings, potentially death certificates afterwards, and a lot of the other things that we consider, right? Not because we want to, but because that's the reality of codes. So is this better? Maybe. So how did they get their program up and running in St. Paul's? So this is a fantastic quote that I had. It's hard, right? This is something that is very controversial. It is something that requires a whole lot of moving pieces, but in the end, it's something that benefits the patient, in my mind, and certainly in their minds as well, because they were able to create this program where they're actually starting to see good results. So before he started anything, Brian, who's one of the staff at St. Paul, did essentially a needs assessment. So they're looking at their numbers in advance based on their pre-hospital arrests. And he takes call for apparently their whole catchment for EMS. And his impetus for this was he was noticing a lot of young people who were dying of refractory VFib or other arrests that he felt perhaps we could do more. So what they found based on this assessment is they would have about 15 cases a year, and they would have about 30% survival, based on the numbers that he ran. So after he did this was a 2-year process where they had stakeholder meetings, they had meetings with their administration, meetings with their CSICU, meetings with their CV surgeons, meeting with their cardiac anesthetists, meeting with their ICU. You can see that there's a lot of people who need to be involved in this. And the argument and the pushback that he was getting was essentially saying, does the evidence support us implementing a cost and resource-heavy modality? Which is a valid argument, but ultimately what they were discussing is where on the diffusion of innovation curve do you want to be, right? Is this something where you believe you're going to be able to push the envelope and actually save lives, or is this something that you think is just going to utilize resources that oftentimes we don't have in Canada based on our funding models? So again, had these discussions, had 6 months more of monthly stakeholder meetings until finally they got everybody on board and were able to get the program started, as you've seen on that last slide. Then they also had an economist or administrative fellow who was looking at the true fiscal cost of this versus the outcomes, and I believe that they were looking in quality of life years. So on average, $50,000 a case, again, 30% survival. It's very hard to put a dollar value on the cost of a life or on the value of a life. But ultimately, you have to look at saying, are we going to be able to save more lives, or are we going to lose the ability to save lives based on this cost funding model because we're taking away from something else? So this is their time frame, as we sort of talked about. These are their goals. So from the time EMS is calling their code ECPR, they want to get to the emergency department within 30 minutes. But they want them to call within 15 minutes of arrival. So again, this goes to the stay and play versus scoop and run mentality of pre-hospital EMS. So this did have to make some changes to their system in terms of whether or not they're going to transport people, because oftentimes these are people that would not normally be transported. They want them to get there fast, they want them cannulated fast, they want them on pump fast, and they want it done as early as possible, because they've shown that the earlier you get somebody on ECMO, the better the outcome is going to be. So is it working for them? Well, of their 3 cases, so far they've had 2 leave neuro intact. One definitely neuro intact, one who's regaining neurological function last time I spoke with him in their ICU. So again, as far as we can tell based on these very low numbers, they're getting some efficacy out of it. So what would ED ECMO look like at TOH? So we tout ourselves based on our own motto as a world-class institution, and I believe we are, and I think most people in this room would agree with that as well. I believe that by implementing a modality like this, we would be at the forefront of resuscitative innovation, and I believe that that's something that we should all strive to. In our department alone, we have almost 60 residents, we have over 70 staff, so certainly the infrastructure from our end is there. And I certainly believe that the way resuscitation and medicine in general is going is to a multimodal, multidisciplinary model. This pushes us in that direction, where we're able to interact better with our colleagues, make better, faster decisions, and make perhaps life-saving decisions and interventions faster. Obviously, the research potential for this is enormous, because there are elements that we can use this cardiogenic shock. We talk about overdose. So there's a lot of tox literature, but as with all tox literature, it's case-based or series-based because they don't have the ability to run this because we don't have the numbers. So beta blocker overdoses, calcium channel, anything else that's cardiotoxic. The tools are here. right? We have an institution where we have a heart institute that's directly next door. We have surgeons all over. We have residents from all, and fellows from all of these programs. So the ability is there. The controversial but truly interesting point also when we talk about organ donation, it would be a side benefit of putting more people on ECMO. This is not the indication to put somebody on ECMO, but if we're able to get more quality of life years because of more and better organs to transplant because people are on ECMO, that does have a fringe benefit or a direct benefit on other people who will improve their quality of life because of it. So these are all the people directly affected by a program like this. First and foremost, we would have to have people from our own emergency department believe in this program. Like I said, I believe it. I believe that we could do it, and I believe that it's viable. Of course, I don't have the years of experience, and I don't have the level to sort of push people into wanting to do it. So it's something that we would just have to believe in and give it a try. I sat down with Bernie McDonald, who's the medical director of the CSICU, and Govinder Gill, who's their head perfusionist. So, again, everybody is sort of, their eyes perk up a little bit when you say the words ED ECMO because they're like, really? I've had the good fortune of being able to do some work in the CSICU, so I know both their infrastructure and their personnel quite well. Bernie is very open to this. That is where all of our ECMO patients are going right now. That is, there's no other place at TOH that is running ECMO. The only other place in the city is CHIO, where they're running it. And Govinder was saying as well, he says, we have somebody on call 24/7 anyway, as waiting for an ECMO call. Because CHIO has instituted their program, and they pay in advance for their perfusionist hours, they hire 2 more perfusionists because of that. So there's extra perfusionists versus what they need to run their ORs. So they are available. However, that becomes one of the questions. This is Dr. Gleaner, who just came from Brussels relatively recently, and his wife was kind enough to come today, Dr. Darok, who used to run an ECMO unit in Brussels. I managed to get chasing him down because everybody's very busy last night. And again, I mentioned the words ED ECMO, and rather than pushback, I got sheer excitement from him, which was quite refreshing. So when we're talking about cannulations, and the reality is we would not be able to cannulate in our department. We have 70 staff. Maintaining competency with our low number of cases is not a reality, but we are all able to get arterial and venous access, call a CV surgeon, have them come and upsize, whether that's percutaneously or a cut-down method. As we saw in St. Paul's, they're able to get them there. The goal is within, I believe, half an hour, and they were there within 4 minutes. So if we're able to find a system that works, and again, this is not going to be a magic system, it's going to be something that's going to take work, I believe that we're going to be able to work with our colleagues and make this happen. I invited both Jack and Jim Worthington to this talk because I feel like we need to have somebody from the senior admin give us their input on it. Unfortunately, neither were able to make it. However, both have asked me to sit down with them and discuss it with them, just so they can have an idea about what this means and where it would take us. I never had a chance to speak with Dr. Pagliarello, but again, the reason I put him in here, even though ICU would not directly be involved in care, is that organ donation, for which he's been a major champion of, would become a very, very serious side effect or side benefit of putting more people on ECMO. And again, we need to look into the quality of life years that we would gain from this. Of course, EMS is going to be hugely involved in this project, again, making it yet another stakeholder and somebody else that would need to be at the table. And we also have to think about our taxpayers and our patients, right? Is this a fiscally responsible modality that we should be implementing here? And are we going to be saving lives? Because ultimately, at the end of the day, our job is to try to improve the outcomes of people who are coming to see us here. This is just an email I got from Jack. So, it's pretty clear that this is what is the direction that a lot of hospitals are heading. So how much does it actually cost? So I got in touch with Maquette, who is the system of the ECMO unit that I showed you at the front, the Cardio Help Eye. So it's $110,000 for the actual unit itself. And if you're putting that into similar terms, does everybody recognize this machine? So the Da Vinci. Do you know how much the Da Vinci costs? $2 million US. And it has, in my mind, shown really no added benefit for any patient. So why are we spending $2 million and a lot of fundraising for something like this, where we could be spending $110,000 on something that is genuinely saving lives? So that's just a comparison to keep in mind. The other fixed cost is that we would need to pay for perfusion hours. So it's an advance cost, meaning we say we would pay for $5,000, $6,000, $7,000 perfusion hours per year, and that allows the perfusionist group to either purchase more perfusionists or have somebody on call 24/7, because that would be the only way that this would run. And then talking, obviously, the University of Ottawa Heart Institute is a separate entity from TOH. So if we're sending all of our patients there, do we need to find some element of remuneration? It's the hardest word in the English language. To send to them if we're doing this on an ongoing basis. Of course, we don't know what that would be. And then, of course, training costs for everybody. And then we talk about the ongoing cost. The disposables, meaning the pump and the tubing, is about $1,500 US a patient, right? So it's not a lot in terms of equipment. It becomes more of the people managing patient care that becomes expensive. Of course, this is not, I can give you a glowing talk on why ECMO is great. ECMO comes with a whole host of problems, and that is not to be overlooked. It is expensive, and it is resource intensive. So even though I think that this may be beneficial in certain instances, we do have to recognize that once they leave our department, this is something that may last for days at a time. And then the other question that nobody has quite answered yet is, how long do you leave somebody on ECMO? How long do you give them a shot before you withdraw care? So, putting somebody on pump for 7 days and moving them to a CSICU is an extremely expensive endeavor. The real estate question is, where would we put them? Right? We already struggle with bed capacity in every hospital in Canada, and certainly here is no different. So when we have to move them to the CSICU, on a whim, that takes away a bed that may have been used for one of their cardiac ORs. So the concern there, obviously, is that if people are waiting for cabbages or valves or heart transplants, and we have taken up a bed with an ECMO patient, is it a fair trade? And again, it's very hard to say. And these are patients who are booked in advance versus the acute cases, and this is going to be a difficult question to answer, but something that I think that we can work with. So what are we going to do from here? I think that there very seriously needs to be a needs assessment, right? I can, again, give you all of my thoughts, and a lot of it is anecdotal, but we need to see if we actually have the numbers here, which I believe that we would. I had a chance to speak with Steve Brooks, who's out of Kingston, who's one of the big CPR researchers, and him and Eric Bruder actually ran this needs assessment in Kingston. They had multiple stakeholders, and they found that they only have about 5 cases a year. So you can imagine 5 cases a year, you're going to struggle to implement something that's going to be this resource intensive. So they essentially stopped at that level. Again, EMS, we would have to discuss who would be transferred based on criteria. And again, it would have to be strict criteria with very strict patient assessments. And of course, we'd have to look at who actually arrests in our department, because they would still be eligible for this, I believe. We need to have people from our administration involved, because this can't happen without them. Like I said, Jack and Jim have been very open to at least sitting down and discussing the concept, which I think is really important. And the other interesting thing that Dr. Brooks was saying is that there's an ECMO symposium that they're having, which is essentially a national think tank that's happening at the Resuscitation and Motion Conference, which is happening in May in Toronto. This is going to be, again, multidisciplinary, looking at people who have already implemented these programs and people who are looking to implement these programs, as well as including people like economists, people like ethicists, people like the docs and the patients who are going on this. I don't think patients coming to this one in particular, but it's going to be somewhere around 20 people. And Steve has been mentioning that perhaps trying to get me into that group so we can see how things are progressing across the country. I think most importantly out of this whole thing is that you have to remember what we do matters, right? We see people, we save lives, and I think that if we're able to get people like Ralph to walk out of the hospital, then we're doing something good. Thank you for your time.
probably give us a better sense of should this be something we're implementing? You know, has anyone done that?
So both Brian Grinnell did look into this in terms of their costs, their fiscal costs. But like I said, you know, that there is a responsibility to taxpayers. But how do you put the cost on a human life? And that's I don't know the answer to that. So what they have done is look in terms of quality of life years, which I think is the best way that we're going to be able to say if we are actually improving quality of life in a number of patients based on this modality, based on X costs, then I don't know what that line is going to be. But that's where I think we need to get economists involved, which they have done. And we need to get administration involved saying what is going to be the threshold for this becoming a viable modality. So it's going to be a discussion that needs to be had, and I think it's going to be site-specific, because in Kingston they felt it was not going to be viable based on their costs. Atul?
Just building on that point, it's generally going to be something that may be site-specific, but it's going to be a province-wide decision. There is a framework for those kind of decision-making. The government farms it out to HMO. There's a group called the Ontario Health Tech Assessment Committee, which needs to work. Not on this, but on. So the requests come from the hospitals and other people who are interested. I happen to sit on that, and one of their cutoffs in health tech assessment, they talk about 50,000 for quality adjusted like year as a cost effectiveness ratio is one of their benchmarks. And then the OTAC will review all the evidence. This sounds a bit too early to come to OTAC, but they'll review all the evidence and then make a recommendation to the government. The government takes all sorts of other factors into account. You mentioned 50,000 per case. Now that is based on about how many cases per year.
So based on their assessment. So the question, just so for everybody who can't hear at home, initially was Shabazz asking whether or not there's a cost-benefit analysis that's been done in terms of whether this is a cost-feasible element. And Dr. Kapoor is just asking $50,000 per case based on how many cases. Their numbers were 15 cases a year in Vancouver at St. Paul's.
And have they done long-term assessments to assess qualities? They're just being discharged neurologically intact. Do we have an idea of how many years
Yeah.
they're getting there?
So the question being now is, do they have any idea of long-term data? Their program started in January. So no. They know that they're still alive now if they're alive, but we have 4 months. So Dr. Vancourt?
Great talk. I have a few comments around all the time. First of all, there's no doubt in my mind that there's a number of patients that will be saved today that have otherwise died. But then you mentioned early on this is meant to be as the very last resort when the patient would die anyway. But then you look at St. Paul's experience, and it's like as quickly as possible. So I'm also absolutely convinced that the benefit of this is inflicted. Because there's no way that some of those patients that we put on ECMO can survive, and that all of them are hospitalized. It's just not possible. There's some, just like TPA, early TPA and the stroke miraculously goes away.
Yep.
So there is a bit of a selection at first where maybe the benefit is attributed to ECMO in patients that are hospitalized, maybe who survive. So that's one thing. I think in terms of the fiscal responsibility and improving cardiac arrest survival overall, there's also lower hanging fruits. Current interval from arrest and first shock at our own institution in non-monitored areas is 10 to 12 minutes, when the bill should be 3 to 4. So that, if you just optimize this, you can possibly have a similar impact or greater. The other big thing as well is neuroresuscitation and termination of resuscitation in the ICU happens not necessarily here, I don't know our numbers, but overall it's being done way too quickly. So many hospitals will permit life-sustaining procedures for 24 hours. Recommendations are to do this longer. So there's other things that we can optimize in the system that may end up having just as big or bigger of an impact as quick note on the Lucas devices and so on. One of the big challenges is you have to have a really well-coordinated team to put it on quickly without causing a long pause in CPR. That's the biggest challenge with resuscitation. We feel that might be why so far it's never been shown to be beneficial. And of course, a situation where you can't use CPR forever, you should use one of those devices. Where I see there might be some interest in using those things is we're getting closer and closer to telling people what the
So just very briefly to summarize, if I can remember it all. So Dr. Vancourt is saying that it's unlikely that 100% of people we're putting on ECMO would have otherwise died. He believes that the biggest issue is going to be a well-oiled team in order to put it on quickly, so you're not losing time. What are the other 2 points? Don't terminate efforts too quickly, yeah, and so that... Right, and the other thing is so we can improve our shock time to shock, essentially, and our CPR quality versus putting people on ECMO. So there's other things we can optimize. So just to respond to those very quickly, I agree with all of those points. I think that the SHARP data itself, in terms of what they've implemented for their arrests, is beneficial as well. So that they're showing that ECMO itself is not making things better. Them being better is what's making things better. In terms of time to shock, I 100% agree. And the reality of the people going on ECMO should be that they have failed ACLS. And what that time determination is hard to say. Brian Granow and Jim Christensen did do an analysis of this, and they looked at arrest times. It hasn't been published yet, but he sent me the proof, which essentially showed that after about 16 minutes, your ROSC rates decline, and after 24 minutes, your rates of ROSC are extremely low. So from their perspective, based on their analysis, they've shown that the earlier you go on, the better, which again may not necessarily mean that you wouldn't have gotten ROSC, but it's that golden time frame that we still don't know exactly where that may be. Go ahead. So the question again was, have they used ultrasound to look at myocardial contractility to assess for outcomes? There are places where they will assess for ROSB, so return of spontaneous beating, meaning if somebody does not have any beating, they will terminate their ECMO much sooner. So that becomes a prognostic factor. And the other thing is that the vast majority of people are using this for VF, so shockable rhythms, unless it was an immediately witnessed asystolic or PEA arrest. But we know that those outcomes are much worse. And certainly when you have a shockable rhythm, the thought is that it's primary cardiac. So that just by the numbers, if you can get them to the cath lab and open up their lesion, you may have a better outcome. Asystole is an exclusion criteria in at least 2 of them, which would be no beating, and then PEA, again, pseudo-PEA versus PEA, which is another hot topic, so hard to say. Anybody else? Jeff? Yeah.
Right now at TUH, at the Civic anyway, like I've at least in my career had 2 patients end up on ECMO and had a PE. I wonder if you could comment on what the current practice is to have a patient who's critically ill getting put on ECMO that might not be quote-unquote ED ECMO, but it's still an option in our outpatient.
Yep. So the question is, Dr. Lepard has had a couple of people, one with ECMO, one with hypothermia, one with PE, end up on ECMO. How do we get people onto ECMO aside from arrest if they're not in immediate extremis necessarily? They had arrested on, okay, so they had already arrested, so they are in extremis. So that's a hard question if they're in extremis to that extent. Right now the process is that you call the cardiac anesthesia team. You do not call the CV surgeons necessarily because they ultimately go to the CSICU, and I believe they are the ones who talk to the surgeons. People are getting cannulated in the OR, so they're doing it by cut-downs for the most part. In fact, I believe exclusively here. And they're doing far more VV ECMO. But when you talk to them, both Dr. Gleaner, Dr. McDonald, Dr. Dupuis, who's also the head of their department, they think that this modality is being drastically underutilized in our catchment. And they're speaking more of VV than VA, but certainly for cardiogenic shock, it's indicated when they're refractory to all of our medications that we're giving them. So I know Andy Pan as well, and Maggie as well is here. Andy has sent some people to their unit, one of which I actually took care of while I was on call there, for ARDS. So if we're seeing somebody who's in some type of refractory hypoxemic shock or arrest, that would be an indication where we should be calling for it because we know that our standard measures aren't working. And Andy's point is that he feels that until we're able to better utilize ECMO in these circumstances, it's going to be a lot harder to get something like this running. I think the two are a little bit distinct from one another, so I think that that's a different question, but I think that we probably should be using this more. Okay, thanks everybody.